So we're going to discuss how to collect history information, do a physical examination on folks with suspected sleep disorders, pulmonary. The questions on the form that you fill out, there are very few questions, so what that means is there's not a lot of information that the driver is providing to you in writing, so you really have to be kind of smart and read through the yeses and nos that they put on there. So I don't know if anybody's mentioned this, but there's a difference between regulations and guidelines or recommendations, and unfortunately we have very little in the way of regulations per se for pulmonary and sleep, which means that most of it is based on guidance and advisory committee information, which means it's a subjective assessment that you make. That puts a lot of responsibility on you. It's kind of easier when you have a regulation that says it's this way or that way. And this is the general statement for all the organ systems that they're qualified to drive if there's not an impairment in pulmonary or alertness while they're driving. And that's pretty much the same standard for all the systems. Federal Motor Carrier lists a variety of pulmonary conditions that may impair the driver's ability to safely operate a vehicle. So the essence of all of this is oxygen deficits and sleepiness. If someone has low oxygen levels or the potential for the oxygen levels to drop, and you'll see that these various disorders have acute as well as chronic components, that may be a problem in terms of safely operating a commercial vehicle. If someone is excessively sleepy, that's clearly a problem in operating a commercial vehicle, and there are so many reasons why people are excessively sleepy. There are 3 slides in a row here, and what I did when I originally started doing these presentations a few years ago, there were so many items on the website, and each one had a link to something else. And I found it to be rather confusing to look at it in its entirety. So what I did was I compiled all of this, and so this plus the next 2 are sort of cheat sheets for you as far as respiratory and sleep goes. And it shows the different disorders. It shows the waiting period if relevant, maximum certification time, when it's recommended to certify or to not certify, and if there's any specific monitoring or testing. So it's kind of like a quickie little thing. Let me just tell you that the Medical Examiner Handbook is being revised on the Federal Motor Carrier website. If any of you have looked for it, I've looked many times, and they keep saying it's under revision. So everything that we have here is based on what was in the Medical Examiner Handbook. I would encourage you to keep an eye on the website, and if there are changes, to update whatever you have in terms of your information. And this is certainly one of these areas that's controversial, not so much pulmonary, but the sleep area. So these are the 3 sections. And for example, if you look at COPD, which is certainly very common, there's no recommended time frame in terms of waiting period. That makes sense. This is a chronic disorder. So what you're really determining is how bad is the COPD, and is it at a level that impairs the driver's ability to safely operate a vehicle? That has to always be your underlying question that you're asking. And certainly pulmonary function studies, pulse oximetry, arterial blood gases, we're going to talk about the paradigm that they have in place for a decision tree. I always have to laugh at the pneumothorax. It's really unlikely somebody's going to come in for their exam with a pneumothorax. They also have common cold here. I mean, clearly that's a possibility. But they have specific guidelines that they've listed, so it kind of gives you a sense of where to start anyway. Obviously, none of that takes the place of your judgment. This is the form that you fill out. The questions that are on this form relevant to pulmonary ask shortness of breath, existing lung disease, emphysema, asthma, chronic bronchitis, sleep disorders, pauses in breathing while asleep, which, by the way, people won't know unless somebody is watching, daytime sleepiness, which people will know, but they may not necessarily admit it to you, and loud snoring, which they won't know unless somebody is observing them. So the problem is that people don't know when they snore because obviously they're asleep, and that's the only time you snore. Well, I guess some people snore when they're awake. So the questions that you're asking about pulmonary are really common questions that you would ask any of your patients. Shortness of breath, certainly if they're short of breath at rest, that's obviously a red flag that you need to pursue a variety of things. But most people with underlying lung disease are not short of breath at rest unless the disease is really severe. But shortness of breath with exertion is another issue. If you see them huffing and puffing as they walk into your office, if you see them having tachypnea while you're doing your physical examination, I mean, these are all sort of soft signs that say, you know, why is this individual needing to breathe faster or deeper than they do when they're at rest? Obviously, we all do a little bit, but as physicians, I think you should be in a position to be able to determine what's normal. And we all think that we're normal. So use yourself as a guide if you really are normal. Questions that you would ask clearly: do you smoke? How long have you smoked? Are you short of breath while you're driving? My guess is that most people are going to say no to that question. Frequent coughing, productive cough, wheezing, are they using any medications? Hopefully people will be honest with the medications that they're using, and so you should always say, why do you use this, when do you use it, how often, what are the circumstances? And people that have a short-acting inhaled bronchodilator, in my opinion, should keep it with them all the time, because you never know when there's going to be something that happens. Your physical examination, really pretty simple. It's a lung examination. If you hear wheezing, rhonchi, decreased breath sounds, certainly if they have cyanosis, gosh, I hope none of the people coming in have cyanosis, but these are sort of your general screening physical examination. Nothing exciting there. So if you see any specific physical findings, once again, people generally don't have significant findings unless there's really significant disease. It would make sense to get a pulmonary consultation. It would make sense to get pulmonary function studies. You really want to get a sense of if they have lung disease, what is it, how severe is it, and bottom line, does it compromise their ability to drive safely? Typical tests for lung disease include chest x-ray, pulmonary function studies, drug monitoring, digoxin, theophylline. I really think that's up to the primary care doctor. What are you going to do with those numbers? But nevertheless, they list a variety of things for you to consider. You may ask that that report come back to you from the primary doctor. Most people with lung disease are not using theophylline anymore, although some people may. And you need to document what you find clearly. If they say yes to any of the respiratory questions, you want to get the usual things. How long, how severe, what medications are you using to take, when do you have exacerbations, when do you have symptoms. A driver that's driving and loading 100-pound bales of paper on their truck all day long, I would think is more compromised than someone that's just driving and not doing that heavy lifting. The problem is when you approve their CDL, they can really go to another job. So whatever you're approving them for, you might say, well, you know, this is okay because you don't have a lot of weight to lift. But they could certainly get a different job. I would think that it's the employer's responsibility to some extent to make sure that that individual is able to do that. So from your standpoint, again, the underlying question is safety. Safety on the road. You're not assessing whether they're doing a good job for their employer. You're assessing, are they safe to be driving this vehicle? And that's a little different than what Dr. Pedowitz said, because he was saying you need to assess from a musculoskeletal standpoint, can they do what they need to do? Can they couple and uncouple the vehicle? Can they, you know, do those sorts of things that require some physical labor? I think that that certainly is a problem for a musculoskeletal problem as well as for oxygenation issues. So again, it really depends on your gut feeling. We were talking to Dr. Weiss. I mean, New Jersey Transit may not have a lot of heavy lifting, but Crest Paper may. So they break down a variety of specific disorders. In terms of allergy and asthma, obviously allergies are pretty common. I would venture to say most people in the state of New Jersey have allergies of one level or another. You clearly are not going to disqualify those folks. But education is the key that physicians should be providing. And clearly, making sure that they understand that certain allergy medications may be sedating, that they need to be careful with those medications. Even the non-sedating antihistamines can be sedating for some people. So the individual has to really know their own body and know how they respond. When it comes to asthma, asthma is a completely reversible airflow obstruction. So consequently, with asthma, when you are not having asthma episodes, you're pretty much normal. When you look at a pulmonary function study on someone with pure asthma between exacerbations, the pulmonary function study is completely normal. So a normal pulmonary function study does not exclude asthma, but it certainly excludes significant chronic obstructive pulmonary disease. When you look at asthma per se, With an acute exacerbation, the pulmonary function studies are going to look very much like chronic COPD. You're really not going to be able to tell. So if you're getting pulmonary function studies, you really want to know, is this during a period at a baseline period where the individual is asymptomatic, or is it during an acute exacerbation? I find when people get admitted to the hospital for asthma or COPD, they get PFTs in the hospital. Now, I'm a pulmonologist and I read PFTs, and sure, I'd like everybody to have them. But the fact is that that's really not the best time to establish their baseline. You're kind of looking at them under the worst circumstances. So when you're assessing their driving ability in someone with asthma, you really want to look at them under their best circumstances, because that's the goal of what you want to accomplish with asthma treatment. Life-threatening conditions, bee sting, allergy, huge issue. Clearly, truck drivers are working outside all the time. And so if someone has had this type of reaction, they really should know it, and they should already be taking those precautions. You can't anticipate who might have that condition. But again, this is where the education comes in, to be sure they always have their inhaled bronchodilator with them if they have asthma, to always have their bee sting kit if they've had life-threatening or serious reactions to stinging insects. Hypersensitivity pneumonitis is an interesting disorder. It's not likely that you're going to make that diagnosis. However, it can be an indolent disorder that compromises lung function permanently if not properly diagnosed and treated. I'm going to sound like a commercial for pulse oximeters, but I really think that everybody should have a pulse oximeter in their pocket in their office. It is such an inexpensive tool. I think it's really the additional vital sign. And as we go on, I'm going to show you that there are various steps in the paradigm that say check oximetry. I hope everyone has one. But it's interesting because a saturation level of 90% and lower is considered concerning. Less than 90 has been shown to put a strain on the heart, increased pressures in the lungs, causing pulmonary hypertension. But the fact of the matter is that 92 is not normal. So you should look at your own and say, what are you at a baseline? Hopefully you're normal. If not, check other people in the office. But a normal resting saturation should be between 95 and 98% for most folks. So if you see somebody that comes in and you put the pulse ox on and their sat is 92, although it's safe, although it doesn't qualify for supplemental oxygen with any insurance carrier, it's not normal. And so people with a hypersensitivity pneumonitis may have this chronic indolent inflammation in the lungs that drops the oxygen levels, can lead to scarring and fibrosis, and it may be related to something that they're in contact with on a regular basis at home or at their job. So by identifying, hey, there's something that's not right here, and getting them to someone, you may actually save them from serious chronic lung disease. COPD, most of you have taken care of patients with COPD. People with severe asthma that is no longer reversible because they've had years of damage to the lungs, that becomes COPD, chronic bronchitis, emphysema. People with chronic bronchitis tend to have more airway issues, so they tend to wheeze more, cough more, perhaps have a chronic productive cough. Those folks do better with medications. There's more of a reversible component with chronic bronchitis than there is with emphysema. People with emphysema, because the damage is primarily parenchymal damage, tend to have lower oxygen levels. So it's really tough to make that normal, because I tell the smokers the holes in the lungs from the smoking, they don't heal with normal tissue. They close over, if at all, with fibrosis. And so you're really never going to get completely back to where you were when you're dealing with emphysema per se. But by the same token, that doesn't mean that they can't be treated and optimize the function. Most folks with lung disease have a mix. They have a mix of some airway problems and some parenchymal problems, or all airway. So medications can be helpful for most people with COPD, but not everybody. And the dyspnea on exertion, I mean, clearly this is an issue. I don't know whether you do any type of a mini exercise test in the office or not, a step test or something like that, but that's where you're going to bring up this dyspnea on exertion. And again, if you have a pulse ox, it's kind of nice to throw the pulse ox on while you're doing some type of exertion and see if it drops. Pulse ox should not drop during exertion. It should stay stable or go up, because as you're breathing more, as your minute ventilation increases, you're basically pumping more oxygen into the system. That's how we're supposed to respond to exercise. If the saturation level drops during exercise, that's not normal. That is suggestive of parenchymal disease. Pulmonary function studies, when you look at a PFT, there are tons of numbers on there. Most of them are not well standardized. The number that is most reliable is the FEV1, and this is the one that we generally use in order to assess severity of COPD and asthma. This is a wonderful line. Spirometry should be performed in all smokers over the age of 35. I could probably get a full-time job just reading PFTs if we were doing this. But the fact is that these are the people that if you want to demonstrate that it's abnormal, you really want to get them while they're young. You want to get them before the disease is severe. And if in fact these are abnormal, this is a perfect opportunity to do some intervention and some education to try to prevent the lung disease down the road. On the other hand, if a PFT is abnormal in a smoker that's age 35, 40, I mean, this is somebody that may have other underlying problems as well. So that certainly would warrant seeing a pulmonologist. I don't know whether you would actually order spirometry. You know, some of you are the primary care doctor for the people that you're doing the CDL assessments for. And in that case, then you get the ability to do all of it. You get to decide what tests are appropriate for you as far as their general medical care also. If you're seeing them just as the medical examiner, you know, if you order it, so many tests nowadays require authorizations. I don't know that you're in a position to sit there and have staff calling for authorizations. You know, most of us in the offices, you've got people sitting all day doing nothing but calling for authorizations for one or another test. So the likelihood is you're going to turf that back to the primary and say, you know, I really would like to see PFTs on this person. But whether it's practical to do PFTs on every smoker over the age of 35, you know, I'm going to leave that up to your discretion. If the pulmonary function studies are normal, no further testing is needed. That's what they say. What does that mean? When they're 55 and they're still smoking, you still don't need to do the PFTs? I mean, a lot of it really is your common sense and your judgment. This is a huge issue. Excessive sleepiness is a huge issue that spans everything that we're talking about today from a pulmonary and a sleep standpoint. 70% of cases of excessive sleepiness are caused by narcolepsy and obstructive sleep apnea, according to the Federal Motor Carrier Safety Administration. I'm not sure I agree with that. I think people are sleepy because they don't get enough sleep, because they have bad sleep habits. I really think that's the #1 reason for everybody. And consequently, education. I mean, it's key. For the drivers, you know, they have the duty logs, they have, you know, specific hours that they're supposed to rest. Assuming that they do, somebody has decided that this is adequate. The average person needs 7.5 hours of sleep. Some people only need 6, some people need 9. So excessive sleepiness is very individual specific, and it's really difficult to get a handle on it, because I would think a smart driver is not going to tell you, yeah, I'm falling asleep when I'm driving, if they want to get their med card. And because it's so subjective, it's not that like there's a specific test that you can do that's going to say, yeah, well, you're sleepier than other people. It's not like an FEV1 on a pulmonary function study. So you really have to use your intuition, look at the individual, you know, ask them some questions, get a sense of what's happening. The Epworth Sleepiness Scale and the Stanford Sleepiness Scale are 2 sleepiness scores that you can use in the office that help to give you an assessment. Dr. Weiss and I were talking about that at the break. This is a subjective assessment that the individual gives you on a score of 0 to 3 with the Epworth score. The Epworth Sleepiness Scale is the one that most insurance companies use when we're asking for authorizations for sleep studies, and it's probably the best standardized one. It's very subjective. It says, what's the likelihood that you'll fall asleep when you're watching television? 0, 1, 2, or 3. What's the likelihood that you're going to fall asleep when you're stopped in traffic? Okay? I think a reasonable person that's there for their CDL is going to say, yeah, I don't think I ever fall asleep in traffic. And yeah, I might fall asleep in front of the television. So the numbers that they put down may not be 100% accurate, but interestingly, they're consistent. So when you look at it, and we look at it on every patient that comes in for their sleep follow-up, it's amazingly consistent, because people in our setting don't have secondary gain in trying to convince you that it's one thing or another. They tend to be fairly honest with the answer. So I would say, you know, the Epworth Sleepiness Scale is a great tool. If it's high, I think that's a real significant factor, because it may be even higher than what they've put down. But if it's low, you know, I think you still should ask a few questions and try to get a sense for yourself of whether that person is okay. Under the respiratory section, they also talk about infectious diseases, and you'll see they've got the common cold, they've got flu. I mean, certainly if somebody comes in with flu for their CDL, I would say put a mask on and tell them to come back another time. Tuberculosis, you know, the issues with tuberculosis and atypical tuberculosis is, has the lung been damaged as a result of the tuberculosis? Has the lung been damaged to the point that it's compromising oxygen function and the ability to do things? And all of these go back to the same final common pathway. Safety while driving, the ability to oxygenate properly, and the ability to increase what you're doing without compromise coming from the lungs. They do, however, mention that if you're acutely ill, you should abstain from driving a vehicle for at least 12 hours after taking sedating medications. Again, I think that this is part of the education that we provide. People sometimes don't know. When they see something that says non-sedating, they're like, okay, this is safe to take. And in fact, it may or it may not be. We're dealing with a higher level of concern with the commercial drivers than we are with regular motor vehicle operators, although I think that everybody needs to be safe out on the road. I'm not going to go into detail on this. Again, it's just basically the bottom line is if it's damaged the lung to the point of causing compromise in oxygenation or function, that's an issue. Sometimes the medications can actually cause some damage too, and certainly in terms of liver functions. So if somebody's actively being treated for tuberculosis or one of these chronic infectious diseases, I think you need to basically look and say, you know, let's make sure that there's not side effects from the medications that may be compromising. Non-infectious respiratory diseases, chest wall deformities such as kyphosis, scoliosis, these are problems that can compromise the expansion of the respiratory muscles. Morbid obesity, particularly abdominal fat, compromises diaphragmatic excursion. So all of these things cut down on the ability to breathe and the ability to enhance your breathing under specific exertional circumstances. Cystic fibrosis, interstitial lung disease, and again, we mentioned COPD and pneumothorax. Certification is determined by clinical evaluation. What's the clinical evaluation? Again, your assessment. I still think having oximetry is a really nice number to have. It's an objective number that sort of gives you an idea, well, at least the oxygenation at rest is good. At least it's some parameter. Or the oxygenation is really not where it should be, and maybe I'm missing something. Maybe I need to explore a little deeper. The massive obesity is an issue particularly for breathing, but also during sleep, because when you lay down, the abdominal contents are pushing up on the diaphragm and compromising your ability to breathe. And consequently, people with morbid obesity, even without sleep apnea, may have hypoventilation from the obesity and low oxygen levels during the night, which can lead to cardiovascular problems or disturb their sleep and therefore lead to excessive sleepiness during the day. A lot of people are overweight. A lot of truck drivers are overweight, so you're not going to necessarily say, well, you can't drive if you're overweight. But again, I think the counseling and the education is extremely important. It's tough when you're sitting in a truck for 8, 10, 12 hours and doing nothing but eating. Cystic fibrosis, of course, treatment has improved over the years, and there are people that are living into adulthood, and they may very well be coming in for evaluations. The problem with cystic fibrosis is it's not a curable disease yet, and the exacerbations can be severe in terms of oxygenation, coughing, and symptoms. So, you know, they don't, you know, it's not necessarily an absolute exclusion, but I think I wouldn't want to be the one in the office having to make that decision. Interstitial lung disease comes from many, many, many things, and it may be treatable, it may not. The common pathway for interstitial lung disease is fibrosis, and that would be picked up on pulmonary function studies as well as a chest x-ray. So someone who has shortness of breath while driving, walking short distances, climbing stairs, I mean, these, again, you have to be very careful with this, and that can be the pathway for any of the lung diseases. You know, pulmonary is actually kind of easy. It's like there's just one final common pathway. People are short of breath or they drop their oxygen levels. I mean, that's kind of what the pathway is. So it's really pretty easy as far as screening them, sort of. Pneumothorax, obviously. If somebody has a pneumothorax or they say they were treated for a pneumothorax a month ago, you would really like to get a statement saying that the chest x-ray has been repeated and the pneumothorax is resolved, or there's residual stable from 3 years ago. So you want some statement from somebody that says that's okay. Cor pulmonale is not something you're going to diagnose in the office. These are symptoms of cor pulmonale, but the truth of the matter is that, once again, cor pulmonale is a pathway that many lung diseases and heart diseases take. What you're going to see in the office is most likely edema, and or neck vein distension. And so clearly, if you see edema or neck vein distension, I would hope that you would send up a red flag and say, why? I think that we all should have that question in the front of our minds all the time. Why, 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 why? Pulmonary hypertension, again, is something that you're not likely to pick up in the office on a physical exam or on a history. Somebody may come in and tell you that they've been diagnosed with pulmonary hypertension. And of course, pulmonary hypertension can be primary, as in we don't know why, or secondary, as in we need to find out or we've already found out why that's happening. People with heart disease may have secondary hypertension, pulmonary hypertension. People with severe sleep apnea may, people with low oxygen levels from COPD. So if somebody has pulmonary hypertension, again, I think that's a red flag that says there's an underlying something, probably, because most folks have secondary pulmonary hypertension, not primary, that there may be an underlying something that fits into another category that may require further evaluation or at least further thought on your part. They lump all of these in secondary respiratory conditions, and that includes, they put sleep disorder tests under conditions. I can't tell you how many people do that, but obviously the sleep disorder testing is what you're going to do when you suspect a sleep disorder. I want to spend a minute talking about the pulmonary function studies and what your pathway is as far as lung disease. So if you do a pulmonary function study, there are specific numbers that you're looking at according to the guidelines. And again, this is guidance and advisory, so once again, it's left up to your subjectivity. If the pulmonary function study is normal, there's no further testing that's needed. Screening pulse ox or arterial blood gas are indicated when the FEV1 is less than 65% of the predicted value, or the FEV1-FVC ratio is less than 65%. If you jump to this, I took all of what they had and I tried to put it in something that made sense. If you do spirometry and it's normal, there's no further testing needed. If you do spirometry and the numbers are in this range, then you need to do oximetry. If you have a pulse ox in your pocket, you're already at that level, even if you don't do the pulmonary function studies. So I think, again, as I said, I sound like I have stock in this company, but I think you need to have a pulse ox available. If the pulse oximetry is more than 92%, no further testing is needed, that's because it's safe. Doesn't mean it's normal, but that's because it's safe. And again, you may still opt, if you see a 92% saturation on somebody that has no other reason for it, to say, I really think that we should, you should talk to your primary, that you should get pulmonary function studies, that you should get a chest x-ray. Something else may be going on. Doesn't mean you can't certify them, but it means that they may need further evaluation. If it's less than 92%, then you get a blood gas. The specific numbers for the blood gas is if the PO2 is less than 65 or the CO2 is greater than 45, you don't certify them. Now, that doesn't necessarily mean they fail, because if they have underlying lung disease that hasn't been diagnosed and it's treated, these numbers may all improve. So you could give them a conditional certification. You could give them, the opportunity to come back at whatever point in time. We were talking about the fact that when people are right up against the last day and they're coming in for their med card, it's tough, because then you're saying to them, you can't work. Your livelihood is compromised until you get this taken care of. So it's a huge issue to say, no, you can't drive at all from today, as compared to, you got a month to get this checked, or you've got 3 months to get this checked. So it really depends on your assessment of their safety when they're driving. But I think this is kind of a nice, helpful path for you to follow. So we're going to change gears now. We're going to talk more about sleep disorders. Some of the terminology that I'm going to use, you're familiar with some of these, of course. AHI stands for apnea plus hypopnea index. This is the main number that's looked at in terms of grading normal, mild, moderate, and severe sleep apnea. PSG is the nighttime study. It's a full in-lab sleep study that monitors 16 channels of information, including sleep stages by EEG monitoring, airflow, oxygen levels, effort to breathe, EKG rhythm, and a variety of muscle leads. So it's a comprehensive assessment that looks for a lot of disorders, not just for sleep apnea. An MSLT and an MWT are daytime nap tests that are looking at how sleepy someone is, and they're done differently. The MSLT is basically saying how quickly does someone fall asleep when they're allowed to. They lay down, they're given 20 minutes. If they fall asleep, they get 20 minutes after that to see if they go into REM. This is the definitive test for narcolepsy. The MWT is a test that says, okay, we're going to have you sit here in this dimly lit room without stimulation for 40 minutes, and let's see if you can stay awake. It's not easy, and there are some employers that ask for this test. And if they fall asleep for 30 seconds, and that's basically the epic on the sleep monitoring, that's considered sleep. So they literally can't even doze. So this is a very sensitive test, although difficult for many people to pass. It certainly is a great indicator, because if you're driving, that's the test that's going to say, can you maintain your alertness for 40 minutes while you're driving in boring traffic at night with lights, in your eyes? CPAP is continuous positive airway pressure. BiPAP is bi-level positive airway pressure. We'll talk a little bit. When you look at the airway, this is where snoring and sleep apnea comes from. Snoring is a sound that air makes when it's hitting turbulence, when it's going past a partial obstruction. However, the air continues going through and you're breathing. Upper airway resistance, and there's another slide on this, but I'm going to talk while we have the picture. Upper airway resistance means that the airway is narrowed, but you're still able to get the airflow through. You're working a little harder to do it. Your sleep is a little more disrupted, but oxygen levels are still staying okay. And then there's mild, moderate, and severe apnea. Anything that causes the blockage back here that becomes complete or significant enough to drop the airflow is going to be a significant event. You can see the majority of it is coming back here. It's the interface between the uvula, the posterior pharyngeal wall, the tongue. The tongue is attached at the jaw, so if the jaw is back, retrognathia or micrognathia, or it just has a tendency to ride back, which if you look at people, many people have an overbite, that means that the tongue lives further in the back of the throat. And certainly on the back, everything drops in the back of the throat. So the back tends to be a worse position for most people with snoring and sleep apnea. The side tends to be better, although some people are equally severe in all positions. The apnea is defined as cessation of airflow for 10 seconds or more. There are 3 types of apnea. Obstructive apnea means the airway is blocked. Central apnea means the brain is not sending a message to take a breath, so consequently there's no effort, there's no airflow. And mixed apnea is a combination of the two. It's a mixture of central and obstructive apnea, meaning there's more than one problem. So if you're doing primary care medicine or even as a specialist, I wanted to point out that sleep apnea is very common. If you're seeing people with hypertension and asthma and a variety of other conditions and you have nobody in your practice with sleep apnea, there's a fairly good chance that you're missing people that have sleep apnea. There are certainly people that are more high risk. Older people, overweight people, people with hypertension, particularly if it's resistant hypertension. These are all indicators that say maybe there's something else that's going on at the same time, or maybe these variables are putting this individual at risk. I always tell people as we get older, everything tends to get a little more floppy, and so consequently, if you haven't had sleep apnea when you were younger, you may have it when you get older, simply because most of us tend to gain weight as we get older, and on top of that, the tissues are really not as firm as we'd like them to be. Again, this is the form that you have, the question regarding sleep disorders, as we talked about, pauses in breathing, daytime sleepiness, and loud snoring. So if you're lucky enough to have someone in the bed with you who happens to notice and happens to tell you, you may know that you have these issues, but many people have sleep apnea and they really don't know. Sleep apnea is a silent killer because it really is attacking you when you're asleep at night. So people may not know and they may not be lying to you. They may really not know. Nighttime symptoms include not difficulty falling asleep. It's not initiation insomnia, but it's difficulty staying asleep. So frequent awakenings. People often say they wake up and they really don't know why. And sometimes it's a pause in breathing or a snort that woke them up, but when they wake up, they're breathing okay. So they're not really short of breath at that time. Tossing, turning, frequent bathroom trips, loud snoring. Certainly if somebody wakes up with a loud snort or gasping, there's a fairly good chance that the airway had been blocked. And waking up in the morning feeling not refreshed, feeling like they didn't really sleep, going through the day and being draggy and tired. There's a difference between tiredness and sleepiness. Tiredness may compromise reaction time for drivers, but it's not nearly as bad as sleepiness. Sleepiness is you're closing your eyes and you're actually falling asleep or having micro sleeps. The daytime symptoms are symptoms that the individual would be aware of, and that includes daytime sleepiness, chronic fatigue. They may describe it as fatigue, tiredness, and part of that Epworth sleepiness scale is differentiating when it's really sleepiness from when it's tiredness or fatigue. Intellectual changes, personality changes, irritability. You really don't want the truck driver to be ticked off at somebody that cuts them off. You really want to have pretty much a calm demeanor. And impotence is enough to scare most people to say, hey, I ought to get this taken care of. Physical findings, frequently obese, not always. You can be skinny and have sleep apnea, so don't let that fool you. Short, thick neck, greater than 17-inch neck circumference. I don't know whether you check neck circumference or not, but that's, again, you can kind of eyeball most people and see, kind of whether the neck is thick. Gosh, I had somebody the other day, and he says, I don't think I have a problem. His neck was 21 inches, and you couldn't even see the neck. It was like, he goes, my wife just made me come. I'm like, mm-hmm. He checks off mild snoring. I said, your snoring's mild? He goes, well, my wife says it's loud, but I don't think it is. Typical answer. So again, he was lucky enough to have somebody in the room that said to him, you need to get this checked. On the physical examination in the oropharynx, if you look at the back of the pharynx, I like to describe it as a room. You've got ceiling, walls, and a floor. Oops. The ceiling is the uvula and the soft palate. So if the uvula is large, if the soft palate is low-hanging and redundant, consequently you're dropping in on the ceiling area and blocking the oropharynx. The sides have to do with tonsils and weight. The weight gets deposited behind the tonsils and may push the tonsils toward the center. So the tonsils may be enlarged, or they may simply be medially displaced from the obesity. And then there's the floor, and the floor is the tongue, which includes the size of the tongue, as well as the position of the jaw, which includes an overbite. So when you're doing your physical exam, even if somebody is denying everything, you might look at this and say, there's just a lot of things that say this individual may have sleep apnea, and you may want to have some evaluation done. High arched hard palate. Your hard palate, the wider it is, the wider the oral cavity is, and the wider the oropharynx is. When it's high arched, it essentially narrows everything, and so that means that your lateral pharyngeal area is narrowed as well, simply because of the structure. In children who have a high arched hard palate, we basically do a palate expander and try to resolve this as kids before they get to be adults. As adults, it's really hard to do that. They literally would have to slice that bone and restructure the musculoskeletal area, which is really, it's not an easy surgery. They can do it, but it's not something that we do very often. We talked about the self-reported sleepiness surveys. There's more than just the Epworth, although that seems to be the one that's most accepted at this point and best standardized. I've got some references at the bottom of most of these, so if you go to this reference, they'll say it's being revised. Because I went in to say, let me just update anything that's there. So, the current federal motor carrier regulations do not provide guidance for screening for sleep apnea. We talked about that in the beginning. A sleep history suggestive of sleep apnea is something that you should be eliciting, and then looking at the high-risk situations. An Epworth sleepiness scale greater than 10 suggests excessive sleepiness. The score goes all the way up to 24, so people might crank out 2s for all the numbers, which is sort of moderate, and there's 8 questions, so that's going to get you to a 16. That's still high. Hypertension that's new onset or uncontrolled, neck circumference we talked about, and BMI greater than 35, which is certainly obese. There's another question that's kind of neat that you can use as a screening question called a stop-bang questionnaire, and it kind of looks at a variety of the things that we just talked about. It looks at gender, neck circumference, age, body mass index, blood pressure. So it's sort of like looking at those things that say, yeah, if somebody has a bunch of these things, maybe, you know, maybe there's something else that's driving all of those. Maybe there's a common factor making all of them worse. So a polysomnography, as we talked about, is the nighttime test. It's the standardized test. It's the test that they basically want to see. However, many of the insurance companies are not paying for it. So what they're doing instead is covering home sleep testing. Home sleep testing is an oxymoron because it doesn't record sleep. It only records breathing. So when you do a home sleep test, the individual is hooking up a few wires at home and you're measuring oxygen saturation levels and airflow. That's it. So if the individual is awake all night, that test is going to be negative. They're not going to have sleep apnea. If they put it on their bed partner or their dog, it may not reflect what they have. Okay. Although my dog snores too, so I'd like to put one on her. So consequently, the home sleep testing is something that the Federal Motor Carrier is not happy about. And again, we're hoping that if they do some revisions, we're going to get a little bit more guidance, because the insurance companies, we go to them and say, we can't do a home sleep test. This is a commercial driver. We need to do an in-lab study. And they're like, sorry, you know, we're not going to cover it. So we're really in a catch-22 right now with what to do with folks. If they have moderate to severe sleep apnea, generally the home sleep test is going to pick it up, assuming that they did it honestly. If they have mild, it's probably not. Most of the Federal Motor Carrier literature talks about an AHI greater than 20 in terms of what they're really concerned about with people. As you can see on here, mild sleep apnea is greater than 5 per hour. So 5 to 15 is mild sleep apnea, 15 to 30 is moderate, over 30 is severe. I will tell you that the amount of sleepiness people get is not correlated to the severity of the sleep apnea. So if you have a brain that notices when the saturation levels go from 95 to 92 during sleep, that may generate an arousal which fragments your sleep and prevents you from getting into deeper stages of sleep. If you have a brain that doesn't notice when you get down to 60%, you're going to sleep soundly and you may not be sleepy. So where do we draw the line in terms of commercial drivers? If they're not sleepy, is that okay, even if they have severe sleep apnea? If they have mild sleep apnea, is it okay to clear them if they're sleepy? So really the key that you're looking at is, are they safe to drive? Not so much an absolute number. Are they sleepy? And it's very difficult to make that subjective assessment. I wish I had absolute answers for you, but I'm basically just setting the paradigm for a thought process. You know, as physicians, there's very little that's black and white in our world. Everything has to do with the art of practicing, and that has to do with your skill in terms of eliciting a history. Treatment for sleep apnea. Behavioral treatment, obviously losing weight is extremely helpful. Many people have bariatric procedures and they get rid of their sleep apnea completely. Some people are able to get rid of the weight without a surgical procedure, which is certainly preferable. Positional therapy, if the sleep study demonstrates that the apnea is only present on the back and not present on the side, they can use a positional pillow, which you wear, that guarantees that you don't turn on your back. The problem is there's no compliance monitoring on those pillows, so consequently, when you see that individual, there's no objective proof that says they're using their pillow. You really don't know that. CPAP is the most reliable treatment. It's the gold standard. It virtually works for everyone as long as they use it. The problem with CPAP is that it's a matter of getting comfortable with it. You have a mask that's on your face, you've got to have the correct pressure, so it's really incumbent on the sleep specialist to be sure that the testing is good, that they have enough exposure to all the different masks and the options and the ramp features and the humidifier and all the things that will make it comfortable. So someone that is using CPAP or has had CPAP prescribed and they're not using it, they really need to meet with somebody that's skilled in fitting the mask properly, in adjusting the pressures. And I've had people come back like a second shot after some years of being away from it because they hated it. You know, I've said to them, give us a shot with this. Let's just change everything that we can, and if we can't get you there, then we'll go to a plan B. You know, plan B being a positional pillow, an oral appliance, or possibly surgery. The surgery, the UPPP procedure, which is the definitive sleep apnea surgery, works about 50% of the time. CPAP works 100% of the time. So there is nothing that's as good as CPAP. The problem is CPAP only works when you wear it. With the surgery, whatever benefit you get, you get. So if you get a 25% improvement or a 75% improvement, that's a long-term improvement, unless, of course, you gain 100 pounds or get really old. I mean, then things get floppy again. But consequently, people that can't tolerate CPAP can still get a significant improvement in their sleep apnea by having the surgery and or coupling it with weight loss to the point that they're no longer a danger to themselves from a health standpoint or to us on the road. There are different modalities that can treat breathing disturbances. CPAP is the standard for obstructive sleep apnea. That is the basic machine that is the one that opens up the airway. So CPAP stands for continuous positive airway pressure. This is a machine that takes air from the room, generates pressure in the back of the throat, and holds it open like an air splint would stabilize a sprained wrist. As long as there's a good seal with the mask and your mouth is closed, the airway is open and there's no snoring. So the selling feature for many people is this is a non-invasive modality that will control all snoring so your bed partner's happy and hopefully back in the bedroom. I said that to somebody the other day, should I write a prescription that she has to come back in the bedroom now that you're not snoring? No snoring, breathing disturbances normal, oxygen levels normal, sleep quality normal, daytime function improved, risk of blood pressure down or better improvement of the blood pressure, lower risk of diabetes, lower risk of heart disease. There's a whole bunch of things, less bathroom trips at night. So consequently, this is, although it's annoying, if people demonstrate improvement, if they feel better, most people will use it. I have a lot of patients that they treat it like the American Express card. They won't leave home without it. And if they do, they come back and they get it and then they go away. Or they're miserable when they forget it and they don't make that mistake again. So consequently, if you don't experience benefit, then compliance is questionable. There are people that will come back and get a compliance download from the machine just when their CDL is due. So the card that's in the machine records forever. It'll record 30 days, 60 days, 90 days, 6 months, a year. So we can download long information and not just the month before they come in. It's kind of like going to the dentist and you brush real good for a few days before you go. So the compliance information is really what you are going to want to know, probably, as a medical examiner. So if you're seeing somebody that has sleep apnea and you know they have sleep apnea and they're on treatment, the question is, have you seen your sleep doctor? Are you using your CPAP regularly? Do you have any compliance information that I can look at? The nice thing about the card is it records the hours of use. It records how many nights you're using it. Every night that you don't use it, it's recorded. If you're using it less than 4 hours, that's considered suboptimal treatment. And so the compliance download shows the number of hours. If you have an auto CPAP machine, which is one of the ones that I've referenced here, this is more comfortable for many people because you can set a minimum number and a maximum number. So the machine auto-regulates during the night depending on the airway obstruction that it reads. So when we look at the download, we can see what the average pressure is and we can see what the maximum is each day. So without doing another sleep study, we can often adjust the machine upward if they've gained weight or they have other circumstances that have worsened the sleep apnea so that the machine is auto-regulating. The older CPAP machines just had a number, and in order to determine a better number without that compliance information, you had to repeat a sleep study. These compliance cards are almost like a sleep study every night because in addition to showing the pressure, they calculate how many breathing disturbances you're having. So if we see on there that the AHI, the apnea-hypopnea index, is less than 5, that number is completely normal. So that says their sleep apnea is completely controlled when they use the machine. If we see that the compliance is good, 6, 7, 8 hours pretty much every night, rare misses, then their compliance is good. I emphasize to them it's really important to use this when you're working. Some people hate it and they'll skip it on the weekends. That's a personal decision that they're making for their health. But certainly when they're driving a commercial vehicle, they need to have that controlled. And again, what I wanted to point out is there are lots of different things that we can change and we can adjust so that it's comfortable for people. So when somebody comes in and says, yeah, I tried that and that didn't work, encourage them to go back again. Technology has changed a lot in recent years. Narcolepsy, you cannot certify as a commercial driver. This is one of the regulations that's an absolute. So if somebody has a diagnosis of narcolepsy, it tends to begin in early life, adolescence, early 20s. It's a lifelong condition. It's associated with sleep attacks. So even if you've had good quality sleep and even if you've had enough hours of sleep, sleep attacks can come on. And it tends to happen in soporific settings, settings that otherwise would cause many of us to feel tired or to be yawning, which I've seen, but not necessarily, the normal person isn't going to fall asleep. They're going to be able to resist. The person with narcolepsy literally can't resist. It's like a sleep attack. Some people with narcolepsy also have cataplexy, which is even more dangerous because with cataplexy, at times of high emotion, you lose all the muscle tone. And that's the classic thing that you think about with narcolepsy. Somebody collapses on the floor and they look like they're dead. And that's not the common form of narcolepsy, but certainly it is one piece of it, and that's even more dangerous. Narcolepsy is diagnosed with that MSLT study that we do during the day. And the way we do this diagnosis is we do testing at night, which confirms that the sleep quality is good and that there's no sleep apnea or other something that's disturbing their sleep, such as leg movements. And then during the day, we do the 5-nap series, and we see how frequently they fall asleep and do they have REM on those naps. REM is the stage of sleep that people should not drop into during a 15-minute period. And people with narcolepsy will drop into REM very shortly after they go to sleep. So 2 of those on those 5-nap series is diagnostic of narcolepsy. The more you have, the more likely it is that it's narcolepsy. If you have REM on one of those naps, you really don't know. It's suspicious but not confirmed. So because it has such significant impact on people, it's really important to make a proper diagnosis. And they may have had iffy tests, and in that case then, if you're getting that information, you're saying, I need to decide subjectively whether their sleepiness is okay. There is alerting medication that you can take that works quite well for narcolepsy and for other sleepiness disorders, but if the diagnosis is narcolepsy, you can't certify them. And that's what cataplexy looks like. I mean, you basically lose muscle tone and you just collapse wherever you are. And you don't want that happening when somebody's behind the wheel. Restless legs is listed on the list of disorders, but there's nothing beside it. And the reason is that they listed it on the website, but restless legs is a condition that occurs when you're awake. So it's not a sleep disorder per se. However, the sensation of restless legs, which is an annoying irritability kind of feeling, may persist when you're asleep. And consequently, your legs may be moving and jerking while asleep in response to that annoying sensation. It's actually called a different name when that happens. It's called periodic limb movements in sleep, and that's picked up on a sleep study. So they use the term restless legs with sleepiness. There's really no such term as restless legs with sleepiness other than the fact that if they haven't had a sleep study, that's what they may be reporting to you, that they have restless leg symptoms and they're sleepy. And so there's a suspicion that something is wrong with their sleep, and that may be periodic limb movements. They are easily treated. So if that's the cause of the sleepiness, that's something that could be treated and they could still have their commercial driver's license. Insomnia is not a disease, it's a symptom of something. So when somebody has difficulty initiating or maintaining sleep, the goal is find out why. And there are so many different factors that can cause that. Environmental factors such as a snoring or a restless bed partner, uncomfortable mattress, room temperature too hot, animals in the bedroom, kids coming in and out during the night. There are so many environmental things. Physical things include allergies, reflux, snoring, sleep apnea. Pain is a really, really common reason for disturbed sleep. And psychiatric issues, anxiety, depression, PTSD, bipolar disorder. So there are so many things that can cause insomnia. It's a lengthy consult that we do in people with insomnia because you're going through a whole long list of things that might be causing it. We do know that insomnia is probably the #1 complaint, and if you do primary care medicine, I'm sure you have people that come in with insomnia complaints. There was a study done some years ago in the Annals of Internal Medicine that said when someone comes into a primary care office with insomnia complaints, the average person is asked 2 questions and the majority are given a sleeping pill when they leave. And that says we don't really have time to get a proper evaluation of these folks. So I would suggest that if somebody comes into your primary office with insomnia complaints, say to them, this is really important. We need to schedule a separate visit to address this specifically, not with the other issues, and really do a good evaluation. And if you're not sure how to do that, send them to a sleep specialist so that they can do a proper evaluation. As the medical examiner for the CDL, you may or may not be able to determine this. So you might ask generic questions like, how do you sleep at night? How long does it take to fall asleep? How many times do you wake up during the night? How many times do you go to the bathroom during the night? These are all variables that say the sleep may be fragmented and they may be more sleepy during the day than they're admitting to. So they may be more readily admitting, yeah, I go to the bathroom 2 times during the night. Yeah, I wake up a couple of times. Yeah, my wife says I toss and turn, rather than saying, yeah, I'm sleepy during the day. So some of these are other factors that you may be able to elicit that gives you an index of suspicion that their sleepiness may be worse than they're actually reporting. As I mentioned in the beginning, I think sleep deprivation is a huge issue. I mean, everything else in the world is more important to do than sleep, right? I mean, whether it's surfing the internet, reading emails, looking at TV, just that me time at night, when everybody finally goes to bed and you've got a little personal time that you just want to have some time for yourself. And it's tough because the folks that are on the road, you're coupling with them the hours that they're trying to work. They're obviously, many of them are paid by the mile, so they're trying to crank in as many miles as they can. Some of them have electronic recording of their miles and their time at this point, which I think has helped a lot in terms of veracity of reporting. But some of them are still recording paper logs, and it is what it is. So consequently, educating them about the importance of sleep, adequate sleep, both in terms of hours and quality of sleep, is important. The sleep testing that we do is looking at the quality of sleep. They may not have control of the quality of sleep unless they have their sleep disorder diagnosed and treated, but they have some degree of control over the quantity of sleep. People that are working 2 jobs, people that are doing, some of your drivers may be daytime drivers, but they may be doing, stocking in a Walmart at night, and so consequently, education is just key. And again, you can't be there watching them every minute. You really are using your best judgment. Excessive sleepiness may come from a variety of things: neurological disease, depression, alcohol, side effects from medications. It seems like almost any medication that you take has the side effect of possibly causes insomnia, possibly causes sleepiness. And if you had numbers that said 3% of people get sleepy with this, 20% of people get sleepy with this, 0.1%, you kind of get a sense of whether that's really a significant issue, because as you know, when they do the FDA stuff, they have to report everything that ever happened during the trials, even if it's not a common thing. So what's the bottom line when people are driving and they're not safe? The bottom line is safety on the roads is compromised. This is what we all want to avoid. This is why you're doing what you're doing. This is why they established the registry, so that the people that are doing these screenings have good knowledge and that they're doing a good job, rather than just somebody walking in the office and having somebody sign off, which is how it was years ago, as many of you know. You're trying to avoid drowsy driving. You're trying to avoid inattentive driving. And when people are drowsy, their reaction time is slow. And Dr. Pedowitz was talking about the people with certain musculoskeletal problems, that their reaction time is slow. I'm going to show you why reaction time is an issue. So if a vehicle is traveling at 60 miles per hour, it'll travel 88 feet per second. If you close your eyes for 3 seconds, which is not very much, your vehicle travels 264 feet. That's really scary. Then the average reaction time when you open your eyes is about 2.5 seconds, which is another 220 feet. That's all before you even start to apply the brake. When you apply the brake, you're dealing with the inertia of the vehicle, and the larger the vehicle, the higher the inertia is. So you can see that's a huge distance that the truck moves before it can actually stop. So 3 seconds of closing your eyes can be devastating and can make all the difference in terms of safety on the road. It's pretty scary, isn't it? Federal Motor Carrier publishes information each year, and they are trying to make things safer, and again, that's part of why the Federal Registry is there. If you look at calendar year 10 and 11 and 12, that was the last information I could get, was half a year for 12. But if we just look between these two, you can see that there's a very small decrease in crashes, a very small decrease in fatalities, a small decrease in injuries, but it's very small change. It's going in the right direction. That's a good thing, but it's a small change. So hopefully now that that now that the registry is in place, we're going to see bigger changes that are happening over the next couple of years. 4 out of 5 fatalities, 4 out of 5 people that were killed as a result of a truck crash were not even in the large truck. So we're bearing responsibility not only for the drivers of the trucks, but for all the other folks on the road, and that includes us, and it includes our family members, as Dr. Pedowitz said. You know, you really want to say, would I feel comfortable with this person driving a tractor trailer behind me? They've done some studies looking at factors related to sleep apnea, and once again, if you look at the folks, it tends to be a bit higher as you get older. It tends to be higher when you're heavier, when you're more overweight. Tends to be higher in people that have high blood pressure. They're the strongest correlations. And those are 3 things that are really easy for you to see in the office. So when you see that combination of things, make sure you're asking enough questions to satisfy yourself that they really are okay. We talked a little bit about the treatment, and here's what the Federal Motor Carrier says. The successfully treated driver may be considered for certification following the recommended waiting period, and that's on those 3 pages of looking at your waiting period. You should not certify the driver with suspected or untreated sleep apnea. Untreated may mean they have CPAP, but they're not using it, okay? Until the etiology is confirmed and treatment has been shown to be stable, safe, adequate, and effective. The waiting period is 1 month after starting CPAP. So let's suppose that you identify somebody that you think has sleep apnea. You say, you know what, you need to go get checked. So they go to their primary, they get a referral to see a sleep specialist. They go to the sleep specialist, they get a referral for the sleep testing. They get the sleep testing done and they go over the test results and they say, yeah, you've got sleep apnea, you need to come back and have a CPAP titration. They wait to get that done. This whole process can take months. So I would encourage you, wherever you practice, to try to maintain a relationship with a sleep center that lets them know you don't want these folks to be losing money by being out of work for 6 months. You want to have them get in, get treated, and get out, because once they get diagnosed and get their CPAP machine, you're still looking at another month. And so if that whole evaluation takes months, this is somebody that is either potentially dangerous on the road if you've given them a temporary authorization, or they're losing money and compromising their ability to take care of their family. 3 months symptom-free after surgical treatment. So they decide, I can't use CPAP, I'm going to go have surgery. So now they go see the surgeon. The surgeon evaluates them and has to schedule them for surgery. So that's tacked onto the additional evaluation period of time, and then it's 3 months after the surgery period of time. So a lot of what you're deciding is, do I really need to have them out of work all of this time? You know, is it an issue? Is there something else that's being done in between to cover their sleep apnea so that they're safe? Are they using a positional pillow? You can't monitor compliance with that, but if you have a relationship with the patient and you honestly believe that they are implementing treatment that's not measurable, you know, I mean, that's an option that you have. If they have an accident, I don't know what liability comes back on the medical examiner. So you're constantly weighing, you know, the health of the individual, the economic impact, as well as the legal impact, and the rest of us on the road. It's recommended to not certify if you have hypoxemia at rest. Again, you're going to be able to get a pretty good idea from the pulse oximetry. If the pulse ox is less than 92%, you're going to get a blood gas, and that's going to confirm the hypoxemia at rest. If they have a diagnosis of untreated symptomatic sleep apnea, narcolepsy, idiopathic alveolar hypoventilation, you won't know that without a sleep study. Idiopathic central nervous system hypersomnia, you won't know that without a sleep study and a daytime nap test, an MSLT or an MWT. And restless legs associated with sleepiness. You may know that by their history, but you may not know what's causing it. So the sleepiness could be independent of the restless legs, or it could be suggesting that there's periodic limb movements, or they could have sleep apnea or sleep deprivation, or, you know, any number of other things. Maximum certification is 1 year. Recommend to certify if the driver has successful non-surgical therapy with an MSLT within the normal range. They're suggesting that everybody that has sleep apnea should have an MSLT. That's not going to happen either, because the MSLT is indicated for narcolepsy. And if you're looking at people with sleep apnea, the insurance companies are generally not going to approve it. So the alternative is to demonstrate on a CPAP titration that they have adequate control. Just being controlled on a CPAP titration in the lab does not mean that they're using the machine at home. I mean, you can have the best of things, but if they don't use it, obviously that's still an issue. So you still need to see your compliance information or some statement from the pulmonologist saying, or the sleep doctor saying they are compliant. Continuous successful non-surgical therapy for 1 month, that's generally the CPAP. Oral appliances can be very helpful. However, the Federal Motor Carrier hasn't listed those as acceptable devices for treating sleep apnea. They've only listed surgery and CPAP. The oral appliances now have little modules in them that they can track the compliance. So in time, they may also be acceptable, and they're so much easier for people to travel with. They're not as good as CPAP, but they're certainly better than nothing. And resolution of symptoms following completion of the post-surgical period, which is 3 months. Certification and recertification, this is when they're coming back to see you. So if they are being treated, they have continuous uninterrupted therapy, they've agreed to do that, you have compliance information, there's no reason that you can't certify them. They should have independent evaluation by a sleep specialist. They recommend yearly. I think that's perfectly fine if somebody has been demonstrated to be completely compliant. We typically follow people every 6 months. They're eligible for replacement of their mask, tubing, filters, and so forth every 6 months, and it's an opportunity to look at that compliance in between that year to make sure that they're really doing it. I don't want to see that they're just using it for a month before I see them. I really want to know that they're doing it on a regular basis. And they can actually bring that download card into the sleep center and have it downloaded even without seeing the physician. And we do that for no charge. We don't charge a copay or any expense for that. They can bring the card in and show it to the physician, and we can get it to whoever needs it. The rest of these slides really talk about the history, the research that's been done, some of the studies that support the recommendations. It talks about the recommendations that were online and then were pulled after that week because the trucking folks didn't want to be screened. And again, I'm not saying that they were wrong. I think that there has to be some compromise in between. And unfortunately, the Federal Motor Carrier is not giving us that guidance at this point, so it really falls back on you as far as your opinion and your responsibility. These are various websites that you can access if you want to get more information. That was the Federal Register withdrawal that I had alluded to, and that was in 2012. Tools for educating drivers. Again, you may choose to have some of these in your office and to provide them to people. And we're still waiting for the official recommendations. I don't know when that's going to happen. Since it now has to be an act of Congress, it's not likely it's going to happen soon. It may happen after we get a new president. It may not, who knows. So you may end up being subjectively making these determinations for a long time. Some people are going with what's called an APAP or an auto-PAP machine at home, and they can use that without coming back in for a second test. And we sometimes will do that too. If we see that somebody is a commercial driver and that they have significant sleep apnea on a testing, we have the ability in our lab to lend them a machine. And what we do is we lend it to them for anywhere from a week to a couple of weeks, look at the download, come up with the proper settings, and then order them a machine. So there are some ways of short-circuiting the pathway. They can plug it into the truck. So if they have a sleeper truck, they plug it in, and I have a lot of people that do that. There are overnight batteries that can be used, and the overnight battery will last for 24 to 48 hours. So people that go camping or they go somewhere where there's no electricity, they can use that. But the sleeper cabs do have a plug-in that the machine's compatible with.